I'd like to discuss about the various techniques which are being evolved in CT navigation. And to start with, disclosures, I have nothing to disclose and there's no industry sponsorship. Uh, Talking about the CT navigation techniques, usually all many interventional radiologists follow the freehand technique, which everyone is comfortable with, and it has a slow learning curve also for that. But once you start using freehand techniques, it is our learning curve stops there. We do not think about how to incorporate newer techniques into it. But when you start doing ablations and everything, you start using ablation, ultrasound assisted techniques, and there are a few more techniques which can be used, such as like the robotic and artificial intelligence augmented techniques as well. And ultrasound fusion techniques are also coming up in terms of CT navigation techniques. So the freehand technique, as you all know, once you have a lesion, you will be looking at the long axis, the short axis, all the three orientation of the lesion, and then try to pass the needle or the antenna right through the center of the long axis of the needle. Here, this is what we've been learning, and over a period of time, we've perfected our techniques by going long axis into the lesion. And a few tricks and tips for the young IAs who are joining in this crowd is to, first of all, once you see a lesion, when you see a patient in your OP, these are the things which I look at once I see the films or see the CT. I try to see what is the approach. Is it going to be an anterior approach or posterior approach or a lateral approach, or how to place the patient, the supine or the prone. This is very important because there are few patients who cannot lie prone, and you have to take that into consideration before planning a procedure. And there are other things like you have to look for other vital structures nearby, and you will have to see what axis are you taking. Like, is it a 2-axis or a 3-axis? What I mean by a 2-axis or 3-axis is, if you're going to see the entire length of the needle in one single slide, in one single image, that is called the 2-axis. And if you're not having a proper window there, and you'll have to convert it to 3-axis or a 3-axis, that is, even if you want to see it in a single plane or multi-plane, you have to work those things just in your OP, not before the procedure. And when it comes to characterizing the lesion, you have to look for the long axis of the lesion. You have to plan the procedure in the long axis, because doing a biopsy is through a long axis is easy, and even if you do it in the short axis, you can get away with that. But when you're planning for an ablation through a short axis, it is difficult. You have to plan for an ablation through the long axis always. And for the biopsies, always you have to take into consideration whether you're using an end-hole needle or a side-cutting needle. And as well, first of all, I always tell my fellows that if you can get the local anesthesia up to the lesion, and your procedure is over 50%, because pain is the most important component while doing a procedure. So when you're able to get the local anesthesia up to the lesion, up to the capsule of the lesion, most of the procedures go comfortably, and you can finish the procedure in 15 minutes. And I always use a coaxial technique. And one thing is very important is feel or feedback or perception. When you're going through the lesion, you have to feel whether it's soft, whether it's hard, whether it's firm. And once the needle is out of the lesion, you have to feel whether it's going through near the structure. So how I usually characterize it, for example, if you're taking a biopsy of a paracardic lymph node, I first of all identify the lymph node, and this is basically during your initial days, try to put try to find out where's the lesion, and try to find out what angle you have to approach the lesion. And the same thing when you are on top of when you are on the patient with the needle, you have to see at what angle, like are they going at 45 degrees or 60 degrees from the lesion. So this is basically for the fellows, but this has to be incorporated all the way. Until date, I do this homework or I do this before I plan a procedure. So this is the same techniques which have been taken up, and with a few procedures we also do ultrasound guided. It's not that once a patient is posted for a a mesenteric lymph node biopsy, I just don't use CT. I use ultrasound also, because ultrasound comes in handy in ways where, for example, a bowel is coming in between. You just keep the probe on the abdomen and push the bowel out and do an ultrasound guided biopsy on table and confirm on CT as well. So ultrasound assisted CT navigation is very important, and for all ablations I use ultrasound as well as CT. So coming on to the next gen or the robotic or artificial intelligence augmented machines which you can see in the market, you'll be seeing like Rubio, Maxio, and the newly launched Casination and Ainu. And these are the machines which we have already worked with. So, and to talk about Maxio and Rubio, they are like they come with integrated planning, robotic navigation, and verification. They support visualization of the lesion and 3D and procedure planning with robotic positioning. And the robotic tool helps, simplify complex procedures. So this is like me doing a procedure on the Maxio for a vertebral biopsy. Although this was it's like a teaching for the fellows. The machine arm, the robotic arms comes in a way that it comes and fixes in a position where you can push the needle into the lesion and take a biopsy from there. So it has its own benefits. So for example, you can do a 3D visualization of the tumor and the critical structures. You can do an ablation planning. You can using multiple electrodes. You can have a post-treatment verification in that system, and the robotic placement of the electrodes. So these are all, I would say that making evidence to the fact that you have done an ablation and or a procedure. Whereas there is a learning curve to it, because this is a study done in a different place where they say that over a period of time the clinical effectiveness accuracy increases, and the period and you can start doing procedures faster from 25 minutes to 10 minutes, and it costs less trauma. That is, instead of repositioning the needle like 5-6 times, even I've had difficulties when there's a moving lymph node, or if it's not planned properly, if you don't have a person to help you, it becomes difficult. And once you use these machines, the needle repositioning time comes down, and the radiation dosage to the patient also comes down with these machines. So these are a few cases which are done by our pain specialist who uses this machine quite often. So he puts in like 2, 3, 4 needles into these facet arthropathies or facet joints, and these are the images from him. And the same over another patient also, for example, is using 6 needles, like in L3, L4, L4, L5, L5, S1, and all those areas. So let me. So this is the. If you can see, I just want to show that when you're using this robotic, you need an assistant, a technician, or someone who is handling. It's like you're using a mouse to use that computer. So it's an era of touch screens, and that is what we have got right now is a Casination care. So what happens is, you as a primary surgeon, you are the only person scrubbed in. You don't need a technician other than a scrub nurse. You have a sterile plastic film on the screen, and you can as well see the lesion in 3 planes, and you can plan the procedure easily. So the system comes with, this is a whole system with, and the difference between the previous ones and this one is, you don't need a plate on the table to be fixed permanently. It can be moved easily to any CT machine and integrated easily. And you have a camera arm, you have a touch screen, and you have a navigation software which is very easy to use. And you have a patient tracking system. It's like you stick 6 beats into the patient so that the patient's respiration, everything can be monitored easily. And there is an optical sensor on top which looks at all these 6 beats, and it is like a GPS. The moment the patient moves a little bit cranial or caudal, the image also moves cranial caudally easily. And there's a patient fixation system so that the patient doesn't move too much during the procedure as well. So this is one of our cases which we have done, which you see a lesion in the segments 8. Quite high, and it's a cirrhotic liver, and it was quite difficult to reach or even plan like a freehand. So at that time we used this machine where we are planning. You see the one marked in red. Sorry. Do you have a pointer, please? Is there a pointer?
Cursor, you can use the cursor.
You see the first pointer maybe in the power point. Sorry. Yes. So here you can see. Here you can see the tumor which is marked in red, and the predictive ablation zone is in orange, and the actual ablation zone is in green. And what it helps us do is, you can see this in the multiplanar view as well. very high, deletion is very high and very subdiaphragmatic. And so what we do is, this is with after placing the needle with the help of detonation. So what we do is, there is an arm, which is a fixed arm, which comes along with the table with the patient fixation device, which will let us to target pinpoint. And there's an arrow device also which comes, which it's a device which comes to help us target directly. For example, it's like holding a pen and you're just trying to move it around to see which is the area, and you use the robotic arm to fix and that position, and then you remove this device and you put the ablation needle on. So, and here you can see that there are a lot of things, a lot of features which comes, like it can tell us whether to push it. For example, if you're able to see here, I can just tell you that if your needle is
Time is over.
Yeah, 30 millimeters are before you can push the needle as well. So, and the software is integrated in a way where you can definitely say for sure if the lesion is ablated or not, if the ablation zone, whether it's E0 ablation is there, and there are specific features in that as well. So there are many clinical data to suggest that it's a very good system, and it's a time saving in many extensive procedures like IRE as well. So the last one was CT ultrasound fusion. It is the next gen. You will be seeing Philips here also has a stall, but we have gone one step ahead and used that in ultrasound guided procedures, like using CT images into ultrasound fusion and trying to target the treatment. And this was mostly used in China and South Korea, which we are trying to bring to India too. So thank you so much for listening, and if you have any questions,
Thank you, Dr. Monish, for a nice presentation. I think you said